Thank you, Mr. Chairman. Yes, indeed, it's a pleasure for me to be here as an interventional radiologist, as I think that next to medical oncology, surgical oncology, radiation oncology, perhaps interventional radiologist or interventional oncology will be the next kid on the block in the treatment of GI cancers. So what's the rationale for liver-directed therapy? Well, it's based on the fact that liver tumors, both primary and metastasis, well, they are vascularized mainly by the hepatic artery, whereas the residual liver parenchyma is vascularized mainly by the portal vein. So the potential indications for liver-directed therapies are liver-only disease or liver-predominant disease. Now, what are the radiological techniques or the radiological tools we have today? Well, in fact, from a historical point of view, first of all, we had the intrahepatic or the intra-arterial chemoinfusion of different drugs directly into the hepatic artery. Then we had the transcatheter arterial chemoembolization, which means that we not only inject drugs, but we will also add some embolic agents. These embolic agents can be non-resolvable like PVA or can be resolvable like gel foam. And then recently, a new technology has been introduced into the market, which is the drug-eluting beads. These are some beads which are impregnated by some drugs in the pharmacy and then will be injected by that directly into the hepatic artery. Another tool is radioembolization, and in most of the centers today where radioembolization is performed, it is done with Y90-based microspheres, whereas in experimental models, also holmium-166 can be used as a radioembolic agent. And then there are some other more experimental techniques like percutaneous isolated liver perfusion or saturation. So let's start by the intrahepatic chemotherapy. Well, the aim, of course, is to increase the concentration of the chemotherapeutic agents into the liver tumors. This is based on the fact that a lot of cancer lesions into the liver, they have a steep dose response curve. So intra-arterial chemoinfusion is based on, especially then on the first pass effect, and on the inverse proportion to the body clearance of the drug, which is very high, for instance, for fluoxuridine, and which is nearly zero, for instance, for irinotecan. So the technique of intrahepatic chemotherapy is double. Well, you can do repeat catheterization using microcatheters every 2 or every 4 weeks, depending on your regimen, to catheterize the hepatic artery, or you can place a more or less port catheter, which is there in place for many months, even years. These port catheters can be placed by surgery, but can also be placed by percutaneous approach. If you do it by percutaneous approach, then you can come from the axillary or from the femoral artery. And of course, first of all, you have to coembolize all hepatoenteric vessels around the liver. And then the catheter, the port catheter, has to be placed with its tip into the gastroduodenal artery. There it will be fixed and by coils and glue, so that your chemotherapeutic agent will go through the side holes, which is located in the proper hepatic artery. And then, of course, before each session of intrahepatic chemotherapy, you have to control your port catheter by an angiography. Here you have a case of such a patient in which such a definitive port catheter, arterial port catheter, was placed coming from the left axillary artery. Then the catheter is going down through the thoracic aorta into the abdominal aorta, and then you see that the catheter is entering into the celiac trunk and ending with its tip into the hepatic artery. Well, is this technique safe? Well, there are only a few reports showing indeed that this is a quite safe technique with some late complications like an hepatic artery thrombosis, especially when you use large port catheters. You can have also port infection and a thrombosis of the access artery, common femoral or axillary artery, but this occurs in less than 2% of cases. Also, the patency of the port are quite good, more than 90% at 1 year and nearly 60% patency at 3 years of use. Well, what about the indications? Well, and these indications are mainly focused on unresectable colorectal metastasis with different chemotherapeutic schemes. However, most of these publications are dealing with small non-randomized studies, and they are unicentric. And it should be good that all these, these good results, in fact, should be confirmed by other, I should say, non-French centers. Another technique, as already said, is then chemoembolization. We have conventional chemoembolization, which means that we will inject an emulsion of drugs, sometimes several drugs, and lapiodol, which is in fact the carrier of the drugs, into the tumor. And then afterwards, particulate embolization is performed with PVA, which is non-resorbable, or with gel foam, which is resorbable. But nowadays, we use more and more drug-eluting beads, which are in fact particulate embolic agents with a diameter in between 100 and 500 or even 700 micron. And this is preloaded or is loaded up in the pharmacy with different drugs. What is possible? Well, you can load up these embolic agents with doxorubicin, irinotecan, oxaliplatin, or cisplatinum, and it depends a little bit on the type or on the brand name of your drug-eluting beads, with which type of chemotherapeutic agent you can load up the bead. What's the added value of using these drug-eluting beads? Well, this is shown in this cartoon here, that by using drug-eluting beads, you will have a higher concentration of the drug into the tumor or into the liver, and you will have a lower concentration of the drug into the peripheral blood, which will then become clear when you see the patient that he will have less side effects due to the chemotherapy. In other words, the safety profile of these drug-eluting beads is better than conventional TACE. This is an example of a patient with an unresectable hepatocellular carcinoma, which was treated with, on a conventional way. And you can see here on the right images, on the right angiographic images, indeed, that the lapiodol is really focused into the big HAC lesion and its satellite lesions. When you use drug-eluting beads, well, they are not opacified when you look on the screen, on the fluoroscopy, but when you inject these beads, you will have a slowing down of your contrast during the injection, and also of the vascularization of your one or both hepatic arteries. And in the end, you will have an image which is a kind of a prune tree image, which means that you only see some slow contrast into the right or left hepatic artery main branch, but yet that you do not see anymore the distal arteries or the arterioles and the parenchymogram of the liver. However, when you do an explant of such a patient, for instance, after a liver transplantation, then you can find on the specimen, indeed, these small beads very close to the HCC lesions. What are today the indications for chemoembolization? Well, of course, it's still the unresectable intermediate HCC in both Child-Pugh A and B stages, and it is clear that using that technique, you do better than just doing nothing for these patients. So what's then the added value of the drug-eluting beads? Or well, this has been shown by or demonstrated by the Precision 5 study. Well, in fact, in general, there was no survival benefit using these drug-eluting beads. However, in some subtypes of patients, indeed, the patients with drug-eluting beads did clearly better than patients treated with conventional TACE. And for instance, these were the Child-Pugh B patients and patients with an ECOG 1 stage, which is, of course, logical as frail patients that do not tolerate very well the side effects which you will have with conventional TACE. Chemoembolization, conventional chemoembolization has been used also for unresectable colorectal liver metastasis. However, there was no study which could show any additional value. With drug-eluting beads, especially the beads which are impregnated with irinotecan, so-called Debiri beads, well, they may have some added value in salvage patients. And there's also a small Italian study used Debiri in a third line, and in this study, based on 74 patients, the Debiri was randomized versus FOLFIRI, and you can see that indeed the response rate was much higher when you use the Debiri, so the local therapy, compared to the systemic therapy. The acute toxicity was much higher, was 70%, but this is, of course, due to the post-embolization syndrome, which you see in nearly every patient which you treat with chemoembolization, whatever the bead and whatever the drug you use. Late toxicity is better for the local therapy compared to the systemic therapy. Then the third technique we have today in our hands is the radioembolization. So what's the difference between radioembolization and chemoembolization? Well, here we use some radioactive microspheres. There are two types of microspheres. There are resin-based microspheres and glass-based microspheres. They are all very small. That means they have a diameter around 30 micron. As I already told you, the diameter of drug-eluting beads is around 100 to 500 or 700 micron. Resin-based spheres, they have a very low activity, 40 becquerel, whereas the glass spheres, they go up to 2,500 becquerel, which means that you need much more resin spheres than glass spheres when you want to inject the same activity. But both are well, pure beta emitters. The Y90 will decay to zirconium-90, and the half-life is about 64 hours, which means that the active period is around 10 days. Important to know also, not only for the physicians who will do the procedure, but also for the nursing staff, is that the tissue penetration of the doses is about 2.5 millimeter, with a maximum up to 10 millimeter, which means that when you are in close contact with these patients, there is no risk for you to be irradiated. In contrast to chemoembolization, when you want to perform a radioembolization procedure, then you have to do, first of all, an angiographic workup, and then in a second session, you can do then the Y90 infusion. What does mean that angiographic workup? Well, in fact, there are three parts. First of all, we have to do an angiographic mapping of the hepatic arterial vasculature because it's a catheter-directed treatment, and therefore we have to evaluate by angiography the celiac trunk, and the superior mesenteric artery. In the second part of the workup, all non-hepatic vessels originating from an hepatic artery have to be not clipped, but coiled with use of a microcatheter and small microcoils. Typical examples are the gastroduodenal artery, the right gastric artery, and others. And last, we will then inject through the microcatheter into the right and or left hepatic artery. We will inject some technetium-99, which is in fact a surrogate for the later Y90 treatment. And why is this important? Well, then the nuclear physician will not only calculate the liver-lung fraction, but he will also look for non-target embolization, and then he will also look for having a good mapping in between your PET-CT done before and the MAA scan. Here you have an example of such an anatomic variant, well, quite an exceptional variant anatomy, which is not so rare in the celiac trunk and the superior mesenteric artery. In this patient, for instance, the left hepatic artery arises here from the left gastric artery. There is an accessory artery going to segment 4, and there is an accessory right hepatic artery, whereas the real right hepatic artery is originating here from the superior mesenteric artery. So coil embolization, well, this is done mainly to reduce the risk of non-target embolization during the Y90, because in contrast to chemoembolization, when you have a non-target embolization with these radioactive spheres, then the complication rate will be much higher. And one of the typical complications of this non-target embolization is well, gastritis or even ulcerations, which may be very difficult to treat even with the best medical therapy. Therefore, in regular cases, we always like in this case, occlude the gastroduodenal artery and the right gastric artery. Also in this case was an aberrant artery originating from the left hepatic artery, but we were not sure which artery this was. So during the workup in the angio suite, we did a cone beam CT when during the injection into the left hepatic artery, and on the left or the right-sided images, you can see that this aberrant artery is going outside the volume of the liver, and indeed this artery is going to the left diaphragm. This was indeed a phrenic artery, which has to be occluded before you can safely inject your Y90 microspheres. And this is then the work of our nuclear physicians. They do the MAA scan, which is nowadays a SPECT CT. They look if there is a good matching in between your PET-CT and the technetium. They look also for non-target embolization, which sometimes we do not see these small vessels. And then also they calculate the liver-lung shunt. If this shunt is above 10%, then we have to reduce the dose. If the shunt is above 20%, then we cannot perform the procedure because of increased risk of radiopneumonitis. So then 1 or 2 weeks later, we can then go for the Y90 infusion, which is again a catheter-directed therapy where we place the catheter and the microcatheters on the same place as during the workup. Then we connect then the microcatheter to the Y90 box, and we infuse very slowly the Y90 microspheres. This is here an example of a patient with an unresectable hepatocellular carcinoma, and this patient had also a portal vein thrombosis, which is a clear contraindication for chemoembolization. And on the right images, you see that after 3 months, there is indeed a good shrinkage of the large tumor into the right liver lobe. So what about outcome for HCC? Well, of course, outcome will be better in Child-Pugh A patients compared to Child-Pugh B patients, but on average, the survival probability at 1 year will be in between 50 and 80%. It has to be known that with Y90, this is a one-shot treatment, whereas compared to chemoembolization, this is sequential treatment of several sessions. But is there a difference in outcome in between radioembolization and chemoembolization? Well, although this is not a randomized trial, and Riyad Salem from Northwestern in Chicago, well, he evaluated his series of chemoembolization versus radioembolization. Chemoembolization was here done with a conventional treatment. It was a triple drug treatment, chemo, and in the end there was in fact no difference in survival, radioembolization versus conventional chemo. What can be said for colorectal metastasis? Well, this is a typical patient which we treated with radioembolization as a salvage therapy. As this patient was refractory to all types of chemotherapy, and you can see that on the PET-CT 3 months after the procedure, there is a good response into the lesions into the right liver lobe. What about survival? Well, there are several prospective studies showing that there may be a survival benefit in these patients, all refractory to the conventional chemotherapeutic lines, but with liver-only disease. And here in this trial published by Cosimelli and co-authors, well, the average 1 year survival was about 50%. However, and there's a big difference between responders and non-responders. Responders, where there was 80% of survival at 1 year. However, the number of responders was only about 40% of cases. There are also a few randomized trials dealing with unresectable colorectal liver metastasis treated with radioembolization. There is one Belgian study where we were part of, and this was published already 3 years ago, but the study was done in between 2007 and 2008, and patients were randomized in between 5-FU protracted infusion versus 5-FU protracted plus Y90. And this small study could show indeed some significant difference in time to progression in between the use of the addition of Y90 versus the arm without Y90. However, there was no significant survival benefit, and one of the reasons was that it was a very small patient sample size. We included only 50 patients. And there was also a crossover, as you can see in the scheme, that patients which were under progression after 5-FU could be treated with Y90. There are also some older studies in Australia done as a first line, and although this is a study which I would show you by Van Hazel, published nearly 10 years ago, where he used 5-FU as the chemotherapeutic agent, which is today become obsolete. But you can see that by adding these surge spheres of the Y90 microspheres, you can have a significant gain in survival. And these studies have now been repeated, but not with 5-FU, but using oxaliplatin, and not in a single center, but on a large multi-center worldwide study, and so-called the SURFLOC study. So the recruitment of this study is just ended, and now we are waiting for these results. So in conclusion, ladies and gentlemen, I think that there's a variety of devices on the market for liver-directed therapy, like drug-eluting beads, like radioembolization, And these techniques, they are feasible in experienced interventional radiology departments with acceptable safety profiles. There is some evidence that chemoembolization, radioembolization has its place in daily practice for the treatment of unresectable hepatocellular carcinoma, and there might be also a place for radioembolization as well as the use of drug-eluting beads, so-called debiri, for the salvage of liver predominant or liver-only colorectal metastasis. However, still more evidence is required before the introduction into first or second line of these therapies, especially then in colorectal metastasis. I thank you for your attention.